and thank you for attending this second edition of our Hearing Roundtable program in 2024. Before starting, just let me give you some information about the hearing group, as well as a few housekeeping details for this roundtable. The hearing group was created more than 15 years ago with the intention to gather expert world centers of implantation of all kinds of hearing devices, and we became like a group, as I say, more than 15 years ago. Since then, we have been meeting once a year to share experience among us and update the information on hearing implant devices. This actually is the picture of one of annual meetings recently we had as a group. And currently we are 36 hearing implant centers distributed all over the world. And I would like to emphasize that most of these dots here on the slide represent teams, including expert in rehabilitation, speech language, programming, imaging, and obviously surgeons. The missions that we have as a group is, number one, to be innovative, trying to stay at the cutting edge of the hearing implant world, trying to be comprehensive, dealing with all types of hearing devices, from bone conduction to ABI, including, of course, middle ear implants, as well as cochlear implants in all their variants. We try to create educational material, such as this roundtable, and other educational tools in written or video format, both live and online. And finally, we are a coactive group. As I said before, we have been trying to set the standards for implantable hearing rehabilitations since 2008. That's quite a long time. And just a short reminder of some important details for those of you connected online. Please quit all other programs in your device, in your computer, your cell phone, whatever, to improve the internet connection. Then mute your microphone unless you want to participate in some moment. And please keep your phones closed but available, since you are going to use them shortly. And at Hearing, we want this roundtable program to be as interactive as possible. And to achieve this goal, you can ask the speakers directly or give your opinion on the topic being discussed by raising your hand. You just raise your hand on the Zoom application, and I will try to bring your opinion to the experts. We will also have captioning. You have a closed caption sign on your Zoom program. And finally, one of the advantages of this program is that it will be fully recorded and remains accessible to everyone in our webpage. With this, the number of people that can watch every episode is much higher than just those connected now online during the real development of the event. The roundtable is accredited as a CPD event, and I will give you the details of the accreditation at the end of the roundtable. As many other online activities, this online roundtable program started during the pandemic, when online meetings were the only way to communicate. Once normality was recovered, we realized that actually this was a very good tool to keep in touch with the international community, and the hearing group decided to start this periodic online roundtable program. Today, we have a very appealing topic. It's bilateral cochlear implantation, and we have added a motto, double the sound means double the benefits, and we will all discuss this during the next 90 minutes. We will all probably agree that 2 cochlear implants are better than just one, but some controversial issues are still present in the world of hearing implantation concerning bilateral cochlear implants. And the question about the optimal and last possible time to go bilateral are repeatedly showing up and seem to remain unknown to the broad auditory community. This is indeed not an easy answer, an easy question to answer, as subject groups and outcomes differ. Economic issues are related to bilateral implantation and are also crucial issue, especially in emerging nations. So we hope that the combined experience of the hearing members in this roundtable can elucidate different aspects, provide a common consensus, and spread the knowledge in the audiologic community. For that, we have a distinguished group of audiologists and surgeons discussing different aspects of bilateral cochlear implantation in a multidisciplinary environment. And to demonstrate that we really want to be interactive, I would like to ask you to switch on the camera of your phone and scan this QR code, or you can also have the option to go to the internet and use this information here. You have the QR code, you scan this QR code that will take you to the Mentimeter. The Mentimeter is the way we have to ask you questions and get the answers online. So please use your phones and going to Mentimeter. You can also go to www.menti.com, and then you can use 7832-5532, and with this code you can enter what is the field of your expertise. It's a very easy question that gives us some information about the people we have in the audience today. So we see that audiologists are the major part right now, more than surgeons or more than any other experts in the field of hearing rehabilitation. So today, the audience today is mainly audiologists. We have a lot of different, we have researchers, surgeons, teachers, speech rehabilitation, otology, neurotology. And as you see, audiologists and research are the main words we have in this word cloud here as the answer. Well, I would like to go to the second question. And the second question is, from which country are you connecting? We want to know how far we can reach in our roundtable program in the hearing group. So we have people from India, we have people from Turkey, Bangladesh, Spain, Germany, Italy, Saudi Arabia, Austria, so Germany, so a lot of different countries, Egypt, we have people from Bahrain, what else? United Arab Emirates. So we have people from all over the world. This is a very broad audience. Well, I hope with this introduction, we can go in depth on the bilateral cochlear implantation world. Let's see if we can clear some ideas, get some consensus, and you enjoy this roundtable today. So to start with this, we're going to have a travel around the world. And our journey starts now by going to Munich in the heart of Germany. And we are here to hear the presentation of one of the experts in the world of cochlear implants, Professor Joachim Müller from Munich. Professor Müller is a leading ENT surgeon and the head of the cochlear implants and hearing prosthetics section of the Department of Otorhinolaryngology, Head and Neck Surgery at the University of Munich. He has been studying bilateral cochlear implantation from the very beginning, and that's a long time. And we are very lucky to have Professor Müller as a vice chairman of our collective and as one of our speakers today. Professor Müller will deal now with the history of bilateral cochlear implantation. Joachim?
Good afternoon, good morning, or good evening, wherever you are in the world. Hello, Xavier, and thank you for the invitation to present on some aspects of the history of bilateral implants, which I will share with you and try to do this in the next 5 minutes. We will have room for discussion. Bilateral implants started back in 1996, and the left side of this picture shows you a painting of a patient who had a unilateral cochlear implant. The white side is bright and colorful, and the not hearing side is described to be dark. This has been changed with bilateral cochlear implants. I'm still waiting for the picture how the dark side developed. And this is the first patient was implanted bilaterally. As Javier said, it was some time ago, and you see a young assistant doctor. Just after the first fit of the first patient. And
Und wo bin ich jetzt? Da. Und jetzt? Da. Und jetzt? Auch da. Wo bin ich jetzt? Da.
Well, these findings kept us busy for the next 25, 30 years. And the impressive of this video is with the Combi 40 at that time, just after fitting, the patient understands without lip reading every word of the doctor, and he has obviously developed directional hearing. That was discussed very controversially in the early days, but in the end of 2000, 2010, more and more papers were published, and it is nowadays accepted. Interesting thing is that the early attempts of bilateral implants showed some binaural interaction by Pellizzone in 1988, but no improvement in speech understanding. That was also the case in a 1993 paper with Van Heusel in Australia, where 2 Australian devices were implanted without any aspects and benefits in terms of speech understanding. Blake Wilson rated these papers discouraging. However, in 1996, we had the Combi 40 available. And if you compare the performance of that device with the state-of-the-art devices in 1994, it was better than everything we had. We achieved 60% monosyllabic words with a single unit, and maybe this was the reason for access. 1998 children were implanted, even we had body-worn processors, and the parents fabricated shirts to wear the body-worn processors under the arms of the kids. Even these disadvantages did not held them away from asking for 2 implants, and thus the implantation number increased. We were faced to stupid and controversial and very aggressive discussion in the scientific community. To give you an idea, at the Antwerp meeting, there was a poster placed by ML, a very known and prominent person in the field of cochlear implants. And that were paper-based posters, and somebody answered the questions that were put on the poster that CIs are better, 2 CIs are better than 1. And I assure you, this was not somebody of our group. In the afternoon, the answers were marked out, and in the late afternoon, the poster was displaced and not shown throughout the conference anymore. So that's an experience with the feelings around the bilateral implant discussion at that time. But the poster addressed have we enough evidence, and are we allowed to do the implant at that time? And from nowadays, we have to answer yes, but the conclusion is we also are responsible for what we are not doing. And following these controversial discussions, we were seeing a generation of children who lost the chances of better hearing. And how good it can go with two implants. We see with Max when he was at the Alaska Award ceremony in New York, chatting to Bill Gates, and Bill Gates even did not see that he has two implants. The outcomes showed the superiority with better speech understanding in quiet and in noise, with the access to all effects that are known from normal hearing persons. And we are able to restore directional hearing to a nearly normal level. Especially the group of Patrick Sen showed that the minimal audible angle is in the same level as with normal hearing persons. And this is due to the fact that the patients have access to intraoral time and level differences, and introducing a level difference in between the two speech processors led to a bias and a shift of the loudness judgment. The same was with time interval in between two speech processors. And on the right-hand side, you see one of the early patients who had no access to intraoral time differences due to the fact that he was wearing a hearing aid for 25 years only on one side. And we implanted the worst ear first and then the second ear. But there obviously the time was too long to develop access to intraoral time differences, despite the fact that he has an improvement in speech understanding. As a logical consequence, later on were single-sided subjects implanted, and also in other parts of the world, advantages for other languages, especially for tonal languages, were worked out. The most interesting thing in the history of bilateral implant was to look at bilaterally implanted deaf children and the question if they are able to develop directional hearing. And at age 5 years, 5 years after implantation, all these children developed directional hearing with an accuracy which was even better than in bilaterally implanted adults. So in general, the bilateral CIs seem to push the speech and language development of these children more than expected, and implantation under the age of 12 months related in even more rapid development and greater lexical vocabulary in bilaterally implanted kids. So the challenge is bilateral CA before age 12 months. For the discussion, I will leave open whether we should do it simultaneous or sequential. Both are optimal ways to go, and there are some aspects that we can discuss and how to find your way through that. So that was a brief ride through the history of bilateral implants, and I'm looking forward to questions and discussions and the other speakers.
Great. Thank you very much, Joachim. That was a very good introduction to the topic. And I would like to start by asking the three of you a question like for the Mentimeter. Is a short answer what I want. We all agree that bilateral cochlear implants are probably better than unilateral cochlear implants. But in your practice, in your own situation, do you have practical restrictions to the use of bilateral cochlear implantation? And the answer may be no, I can use it always. I have some restrictions, or I cannot use bilateral cochlear implants as a routine. Joachim, you can start.
Well, economically, we have no restrictions. Insurance companies pay for it. from a medical point of view, we might see some caution in patients with asymmetric biological conditions or with asymmetric vestibular disturbances related to age. Maybe an 80-year-old man with one functioning implant and no vestibular function on the other side, being implanted, having a little risk of vestibular disturbances, should be considered careful. But practically, we can decide on what's, in our opinion, best for the patient.
Okay, Ranjit, India.
Yeah, the problem what we have is economical restrictions. So apart from that, we don't see a major reason unless otherwise there is any contradicting medical conditions where we can't choose the other side for an implant. And the third reason could be we may need to deny them just in case if the duration of the difference from the first and the second implant is very large, maybe 20, 30 years or so. And that's for other conditions. That's very minimum, but major restriction is economic.
Okay. Hagr, you don't, Rahman, you don't have economic restrictions, I suppose, in Saudi Arabia.
Well, we have restriction for trilateral cochlear implant because it does not exist.
No, it's bilateral.
Yes, bilateral. There is no restriction, and for children, for adult, for anyone, except if they have any problems with the ear, like there's no cochlea, there is no nerve.
Okay, we have a question from the audience. Our chairman, the chairman of the hearing group, Professor Rudolf Hagr, wants to say something. Rudolf, go ahead. Welcome.
Hi, greetings from Dublin in Ireland in preparation for the next meeting. My question, looking to the simultaneous situation, have we really convincing results concerning fitting advantages? And this is a question to all three panelists, because you have implanted two sides at one moment, and then fitting, in my opinion, is much easier and you get better results in a shorter time.
Okay, we can answer now, or we can move to the next speaker that will deal with bilateral cochlear implantation with clinical issues, and we go for the answer afterwards. Do you agree, Rudolf?
Yes.
Okay, well, now we are moving forward, as I just said now, we are just going to the clinical world, and in our trip, we are going to travel with no jet lag from Germany to India, to Chennai. Oh, excuse me, no, we are not traveling to Chennai. We're going to travel to Riyadh, to Saudi Arabia. And we are in Saudi Arabia. Actually, our speaker is not in Saudi Arabia, it's in Istanbul, but he's from Saudi Arabia to meet Professor Abdulrahman Hagr. He's from Riyadh. Professor Hagr is the president of the Saudi ENT Society, as well as of the Arab Academy of Otology and Cochlear Implants. He is a professor at King Saud University and the director of King Abdullah Ear Specialist Center. Professor Hagr is a member and advisor of multiple international societies. He's a real well-known surgeon and ENT expert in cochlear implant all over the world, and is a member of the hearing. And we are honored to have Professor Hagr as one of the active members, most active members of our group. Professor Hagr is going to deal with bilateral CI in adults. Rahman?
Thanks a lot, Jaber, for this wonderful introductions, and good time for everyone everywhere. And I'm really thankful for giving me this chance to present our experience with bilateral simultaneous cochlear implant in adult. And I hope by this presentation we'll be able to answer a lot of concern and a lot of questions that we passed through it a few years ago, and I think we find a good answer for it. So if we look to the history with Professor Müller's, and he explained it nicely, cochlear implant passed through a lot of levels, and it's actually started with adult unilateral cochlear implants. And then with the great success, it moved to the children unilateral, and then bilateral sequential children's, and then bilateral simultaneous. And then few centers nowadays is doing bilateral adult sequential. And I think the ultimate goal that everybody will be interested in it to go to square one with adult and do bilateral simultaneous cochlear implants. But if we think about these issues, there is a lot of concern in those cases. As Professor Müller mentioned also, is first adult, we worried about their balance, and then hearing. What about their hearing until they get fitted with the sound processor? Are they going to be deaf for 1 month until they get fitted for both sides, or shall we wait and implant one side, keep the other side with hearing aid until they are happy with cochlear implant, then we implant the other side? And also concerning the stable map, how long it's going to take them to go for the stable map. The other issues is general anesthesia in adult, and I'm sure every now and then we hear about those side effects of general anesthesia in elderly and the recovery for them and so on, and also how much it could affect their cognitive functions. And with this, we give an extra care for elderly in particular, and children who's younger than 3 years old. This is how it's been shown in the American FDA, the warning for anyone who's younger than 3 years old, and for surgery who's been more than 3 hours. And we know with bilaterals, hardly it takes less than 3 hours for general anesthesia. And what about hearing preservation for those cases? Shall we wait and make sure that we have a good hearing preservation in one side, and then we could do the other side? So these are the top important concern for us when we are doing a bilateral cochlear implant simultaneous in adult. So we look to our experience, and we publish actually a paper in Laryngoscope about bilateral cochlear implant in temporal bone fractures. And we know in those cases, they lost their inner ear function, the hearing and the balance. And in spite of this, they did not show any major balance problems. And even in spite of doing bilateral cochlear implant in those cases, we did not face any major issues with their balance. So they got a trauma to the inner ear twice, and in spite of this, they still were happy with the cochlear implant bilaterally. And then we publish this paper, which is simultaneous bilateral cochlear implant in adult. And we looked to those 27 patients. Their age varies between 19 and 70 years old. And we looked to their main complaint in the first visit. And you could see here, the balance was not a major issue. What was the major issues is the tinnitus, and with the cochlear implant, hopefully we'll be able to handle it. And then loud noise, and they need a few adjustment of their sound, some pain and so on. But all of them are not a major issue to stop us from doing bilateral simultaneous cochlear implants. And this first concern, balance, was not really a major issue when we did a cochlear implant. So what about the hearing? Can we wait for a month and they get fitted with cochlear implant on both sides? In reality, we look to our practice of different cochlear duct length in Saudi Arabia. And we found in Saudi Arabia, we have a different cochlear duct length compared to the Europe's, smaller cochlea, and somehow bigger than other end of the world in Asia side. So we are almost in the middle. So by this, we will be able to see how big is the cochlea, and according to the anatomy of each cochlea, we fit them with the best electrode, and we program it according to this anatomy. But the issue with this one is post-operatively, and how can we manage this by doing CT scan for every patient? And this was not an easy issues for the anatomy-based fitting. I'll let you know what we have done. But look at here, the frequency mismatch with the cochlea, okay? And you could see here with the longer electrode, the standard electrode, we have less mismatch. So the longer electrode for the cochlea, the better mismatch between the default fitting and the anatomy-based fitting. So this is another thing encouraging everybody to look to the anatomy of the cochlea and tailor this fitting according to the frequency for this cochlea. And then the other issue was the CT scan is a major issue to do a CT scan post-operatively to localize exactly where is the frequency for these positions. And we were lucky to find it easy by doing just plain X-ray. And by plain X-ray post-operatively, which we do it almost routinely for all of our patients for different reasons, we were able to use this X-ray to localize the anatomy and the frequency for each cochlea. And this paper, it's already been published, and I hope everybody would look at it and use it and make their life easy. And you could see here, it's been, this software of Autoplan is being integrated in a way that it uses the plain X-ray to localize exactly the frequency after implantations, and accordingly, this will be moved to the maestro, and accordingly, the patient will be fitted on the anatomy. That would make it faster and easier for the patient to understand and to hear easy than what we used to wait for a long time before. So with this, we are able to handle the balance. We are able to get a better fitting and better stable map faster than usual for our patient. But what about general anesthesia in those patients? With bilateral simultaneous cochlear implant, definitely will take longer time than unilateral. It's not double the time, it's actually shorter, but still it's longer. So how can we cut this general anesthesia time? So we thought about doing cochlear implant under conscious sedations in our patient and do them as a day surgery and same day fitting. So we did it even for bilateral cases, and we did them under conscious sedation, and we fitted them intraoperatively, and we sent them from recovery room to their home. So this is another thing that make cochlear implant much easier and much attractive for a lot of elderly patients, because their main concern was not the cochlear implant. Their main concern was the anesthesia. So by conscious sedations, we were able to remove this hassle and difficulties for a patient to accept cochlear implant. And then this is a paper which just been published, okay? And it shows that the early activation, it would give you a low impedance in a cochlear implants. And we know that the impedance is the biomarker we have for hearing preservation. So by doing early activation in our patient, actually, it's another added value that we preserve the hearing. And you could see here in this graph that the impedance is lower in early activation. And believe it or not, this is a result for 2 years. For 2 years, it's continued to show that the impedance is lower in early activations, and this would go more with the hearing preservations in our patients. So by this, we know by doing bilateral cochlear implants, we still have a good chance to have hearing preservations if we do early activations. So by this, we were able to control the general anesthesia issues and also for the hearing preservation. And by this, I think we're almost all ready to go with the bilateral simultaneous cochlear implants in adult with no major concern and worry. This is one thing I would like to show you, that the Guinness World Records for one hand of heavy weight lifting is 300 kilos. This could actually go down if we use 2 hands anyhow. It goes down to 230. But if we both hand together, we could lift 530. This is the records. So you could see it's not actually the double, but if you do not put them all together, synchronizing each other, we will not be able to reach this weight with one hand. So basically, 2 hands definitely will give you better, 2 hearing with 2 ears definitely will give you better hearing. And at the end, I would like also to welcome you all to the 3rd Arab Cochlear Implants Conference in October. Thank you.
Thank you, Rahman. That was very good. I don't know if weightlifting is the same as hearing, but the comparison is nice. So let's go to the question of our chairman, of Professor Hagr, concerning sequential versus simultaneous. I understand that you also prefer simultaneous rather than sequential. Is this right?
Well, actually, we ask our patient what they prefer. Okay, in reality, they prefer to have one surgery, as this is applied to everywhere. For the knee replacement, for any kind of surgeries, they would like to have it once. And I think by doing bilateral simultaneous, we give this benefit in one surgery. And we have seen it clearly in pediatric, how much parents are excited to do it once and how easy for the audiologist and to rehabilitation people to do it simultaneous. So I think the same thing is for adult bilateral simultaneous cochlear implants would give you the same interest from the patient side. So I'm answering from the patient side, not from the surgical, because as a surgeon, all of us would love to do bilateral simultaneous.
No.
Okay, Ranjit, you're the audiologist here. And remember, our audience was mainly audiologists. Simultaneous, sequential?
I would go with simultaneous, but one important reason is it gives you the not just the ease of programming, but also in terms of development of the communication skills and development of the auditory skills is much better when you do simultaneous compared to sequential. Now, when you do sequential, there's always a comparison when you do a programming on the second implant side, and it's always compared with the first implant, say the quality of the sound. So, matching the expectations becomes a little more difficult in all cases, though it's going to take some time with consistent training. The brain will acclimatize over a period of time. But for the ease, I think it's better to go with simultaneous.
Okay, simultaneous 2-0. Joachim, 3-0?
No.
Good.
I think
2-1.
it's a little bit more complex, and we should not discuss it just from the scratch or from the desk. Reality is different and much more complex. We have to differentiate whether it's adults or children. Reality is that the majority of our patient has asymmetric hearing. So for the adult population, we are implanting patients with some substantial residual hearing, and usually they have asymmetric hearing. And these patients go for a while by model, and then the CI takes over, and then we end up with a sequential surgery because of the medical situation.
Okay,
Also,
but this is because of indications, right? This is not.
Yeah, because of indications.
Okay.
We hardly see no deaf patients, completely deaf, waiting for an implant. Those has been operated 20 years ago. And nowadays the knowledge is in a way that if the patient understands more than 30-40% monosyllabic words, he asks for a cochlear implant. That means when he cannot use the phone on a regular basis with his family members, then he asks for an implant. So the situation has changed. In children, we are also facing a situation that they have residual hearing, and they, luckily enough, need not to be completely deaf. And usually also they are facing asymmetric conditions with some benefits from the hearing aid. In children, we are going to lower ages at 1 year, and we love to do them even below 1 year. And then your setting comes into the game. The anesthesiologist plays a role. A 1-year-old child has 500 milliliter of blood. The anesthesiologist should be feeling comfortable in putting this child to sleep. The audiologist wants to do evoke potentials prior to the surgery to confirm the decision. And then you are running into a time problem. And a short anesthesia, or at least the opinion of our anesthesiologist, is that 2 shorter anesthesias are much easier and better for the child than 2 longer ones. And therefore we make the decision individual. About 20% of our patients had been implanted simultaneously, and 80% are implanted as a staged procedure. And a short time sequential procedure with maybe 6 months interval in between.
Joachim, we will deal with this afterwards. The time lapse between the 2 operations.
The real world is not black and white. So
okay, good. I have questions from the audience. I have questions from our chairman, but we are going to move now to the next talk, and then we will go for the questions. So I promised you to have a trip to India, and we are going to India now, to Chennai right now. Okay, so we're now in Chennai with Professor Rajeswaran. Ranjith is the director and chief audiologist at the MERV Institute of Speech and Hearing of Madras ENT Research Foundation. He has co-developed this center as one of the most sophisticated, with state-of-the-art infrastructure and the latest cutting-edge technology to serve the patients. His special focus is on hearing restoration and hearing implants, and we are proud to have him among one of our most distinguished hearing members. Ranjith will deal now with bilateral cochlear implants as the topic of the day, the challenges in emerging nations. Ranjith?
Thank you for the nice introduction. I hope you can see the slide. It's coming up.
Yep, we see them.
Okay, great. So I'm going to talk about the bilateral cochlear implant in a different perspective of emerging nations and what are the challenges that we face and what is the future directions for us to go ahead to improve bilateral implantation in countries like India and other emerging nations.
Ranjit, you have the slides. You have the slides, but not in the format of watching, but just on the format of editing. Just press
okay now.
Now. Go ahead.
I'm sorry. Yeah. Okay. Great. So I'm going to give you a brief overview of how bilateral implants, how it came up in India, what's the present status of bilateral implants in India and other emerging countries in general. The first cochlear implant in India was performed in the mid-1990s, and then until 2008 to 2009, we did not do any bilateral implants in the country. Simply because most of the cochlear implants in emerging nations initially were self-funded, not reimbursed. Now, in general, as we all know, we don't need any great explanation why bilateral is better than unilateral. There are enough publications, though there are certain disparities. However, the bilateral is definitely better than unilateral, and I don't want to go in depth of that. But however, having known that the bilateral is better than unilateral, how come in countries like India and other developing nations where bilateral implant penetration is very low compared to unilateral? But for that, I want to give you a very brief background about how the health structure works in countries like India. Now, we have two governments. India has got almost 32 or 33 states. We are like a United States of India, like United States of America. There are more than 30 states which form a union to form a government as a federal government. The healthcare system has both a state and the federal government, but predominantly the health becomes a state subject more than the federal subject. Now, under both federal and the state government, you have two departments: Department of Medical Intervention, another one is Department of Disability. But fortunately, both the medical and the disability department provide cochlear implant under the state and the federal funding scheme. However, the criteria for the reimbursement or the criteria for state and the federal funding schemes may vary, but availability of the implant is definitely for sure in both the governments. Now, if you look at the basic fundamental criteria, usually, in general, the cochlear implants are provided only for children. There is no reimbursement or funding for cochlear implants in adults in the country all over. And the federal government funds implants for children less than 12 years, but most of the state governments funds cochlear implant for children less than 6 years of age. And both the government support for rehabilitation for at least 1 year. Beyond 1 year, there is no support from the government. The patient has to spend money from their pocket for further rehabilitation. The last 5 years or 6 years or so, the government has also started supporting accessories for these implantees, which includes a sound processor. but they do not give upgrades. Which means if a patient is willing to go for the latest upgrade of the sound processor, it will not be possible for them to upgrade. However, they can only go and buy the old version of the sound processor in case if the sound processor is not working. So the replacement of the sound processor is only if the sound processor is not working and they don't give upgrades case. So this is by far the general criteria and the conditions under which the cochlear implant funding happens in the country. Now, let's look at what are the biggest challenges we face, specifically focusing on bilateral implants. Now, having said, one of the biggest burden or one of the biggest impediment for us to go for bilateral implant is financial impediments. Now, almost 99% of the patients, if you ask them, are they willing to go for a second implant? Most of them prefer to go for a second implant, but the problem was finance. So they have to pay for the implant costs money, and then they have to spend money from their pocket for hospitalization and surgery, including rehabilitation. They have to spend money for the spares, which adds more economical burden because they have to spend money for maintaining the spares for both the implants and also the upgrades. Now, often we see the companies, phasing out the sound processors. When the company phases out the sound processors, some of the patients are left with no choice. They have to go for an immediate upgrade within a limited time frame of time. If they're going to have a bilateral implant, it becomes much more difficult for a family to afford for two sound processors. Just to give you a brief comparison, average income of a household income in India is close to around, let's say, $300 US. The cost of the sound processor is close to around $8,000 US. So that's why the comparison is. So that's why it becomes very difficult for them to afford for bilateral implants. Not just affording for the implant, but most of them are really worried about the maintenance over a period of time, which is quite heavy. Another impediment, which is prevalent in most of the developing nations, is the availability of human resources, the audiologists and the speech language pathologists. This is very, very important. But one might think, what is the role of audiologist, speech pathologist in making a patient to decide for the second implant? Because usually the knowledge of the audiologist and the professionals plus the outcome of the first implant accelerates some of the patients to go for the second implant. In most of the patients, if you look at our own experience, in patients who have received unilateral implant, let's say if you take 100 patients who have received unilateral implants, among those 100 patients, the patients who perform really well are motivated to go for the second implant. The patients who don't perform well, they are not motivated to go for the second implant. So the self-motivation to go for a second implant is also very, very important. No? So this is very much lacking when you don't have a good rehabilitation and audiological support, which is very important for the progress post-implantation. Now, another major factor is the social stigma. The social stigma is not only for unilateral implant. In few cases, we also see social stigma for bilateral implants as well. And another important, interesting fact why some of the patients don't go for the second implant is the peer satisfaction, or what we call it is a peer compulsion. So if you have 10 implantees using or unilateral implantees, and 8 of them could not, or 9 of them could not afford to go for a second implant, and there is so much of influence from the peer pressure where the parents are self-satisfactory that even with one implant, they could do better. And there is no comparison as a peer comparison to see somebody doing much better with 2 implants rather than 1 implant. So this actually demotivates some of the parents to go for the second implant. And we also see some peer pressure where which prevents them to make a choice to go for a second implant. And the last and the most interesting thing, this is among the patients who can afford for a second implant. So previously I was talking about the subjects, those who cannot afford for a second implant, where the financial burden is one of the main reasons, apart from other reasons. In families where the money is not a problem, and some of them do not choose a second implant thinking that there's going to be an alternative medicine, an alternative technology, which will come up, which will restore hearing to absolute normal level. So they want to preserve the ear for the future. So this is quite common, and I would say in my own series of patients those who have can afford for bilateral implants, I would say almost 20% of them do not go for the second implant simply because they wanted to preserve the other ear for the future. So in this condition, even despite intensive counseling, despite a lot of clinical evidences, of course, they still have some own reservations to go for the second implant. So these are some of the common reasons why the bilateral implant is not penetrating. So I just went into a quick survey just a couple of days ago, just to see what is the percentage of people who have opted for a bilateral implant. Is almost 9% of the children who have received cochlear implants are bilateral, and adults who are bilateral. So just 9% out of 100. Now, what is the future? The important thing is, if you ask me whether India does not have money or developing nation does not have money, no, we all have money. Money is not a problem. The problem here is the evidence and creating awareness about the importance of binaural hearing. Now, the real awareness, the real benefit of binaural hearing happens not below the age of 5 or 6 years. You really see it when the child becomes an adolescent and an adult, where the child goes into a real world communication and where the stress for listening, the stress for mental fatigue is going down. So we need to create enough evidences to show the policymakers that, apart from having hearing, there are also other advantages when you have hearing on both sides rather than having one hearing. So when we show those evidences and we create enough evidences to show the binaural benefits are better than monaural benefits, then definitely bilateral cochlear implants are not very far for us. And how do we do about it? The most important thing is we need to collect a lot of data, and we need to equip ourselves to create a very quality data to create evidence to show the bilateral is better than unilateral. And to conclude, we all know that financial burden and lack of evidence is the most important thing to tackle the cost-benefit ratio. So evidence is very, very important to do that. And it's a long way to go for a bilateral cochlear implant. And in many countries, even unilateral cochlear implant is also not affordable. In countries like Africa, we also do a lot of projects with Africa, with the hearing healthcare alliances. We also know what the real problems are. One of the major problems in countries like Africa are human resources. It's one of the major reasons. And how do we achieve it? The most important point is the collaboration. To collaborate with international centers, to create evidences, to come up with good protocols, and create awareness both among the professionals, public, and as well as the key opinion makers and the policy makers is the key to penetrate to more people to get into bilateral implants. Thank you.
Okay, thank you, Ranjit. That was a nice presentation, and we are a bit short of time for the discussion, but we will have more time at the end of the next presentation for discussion. But I just want to recover 2 questions from the previous speaker. So I would like to ask, because this is Rahman, this is a question for you coming from the audience, but actually I wrote it down also in my notes when I saw your presentation. So the question is, what is the reason for lower impedance if we do an early feeding and an early activation? Do you have any idea?
Well, this was a major things that of interest for us, because we've been doing it for the last 13 years, and just we pay attention when we collect all of our patients and we look to the result, and we were shocked that almost all of them, they have low impedance even 2 years after. And looking for this as what could be the reason, and we found that electricity has been used to treat many disease, okay, like even cancer nowadays they treat it by electricity. So we think electricity would be a reason for a better healing inside the cochlea. The cochlea has one of the strongest area of fibrosis. It's maybe the only organ in the body where it has so strong fibrosis that sometimes end up with calcifications. So electricity, it's well known that it interfere with the cell proliferations, and we think that early activation is the time where the inflammatory process, where the time of the fibrosis, and electricity may inhibit this fibrosis, and this is why we could end up with a better outcome with the early activation. Thanks a lot for this wonderful question.
That's an interesting idea. Rudolf, a short question for the speakers. Unmute yourself, Professor Hagr. Right.
Yes,
right.
hey. Thanks to all. Can you hear me now?
Now we can hear you, yeah.
Okay. Thanks to all the speakers for their comprehensive speeches, and also for the moderator for the excellent moderation. This was really interesting. And a special thank to the colleagues from Saudi Arabia, because they have innovative approaches since many, many years. And my question is to this group: how is the percentage of in adults where you have this early activation and bilateral? And is there any psychological burden if you have the patient completely deaf? Most of them have some residual hearing. And if you do it simultaneously in adults, they are completely deaf after surgery. Is there any problem?
Well, tell you the truth, our patient, we did a study on them. They were not all profoundly deaf in both sides. Some of them, they got residual hearing. And we offered them the bilateral cochlear implants as an options. And we were excited that a lot of them, they are interested in bilateral than having surgery twice. Their main concern was the general anesthesia. And although some of them, we did them under also local anesthesia. So we think that patient actually is preferring as much minimal intervention from surgeons or getting to the hospital, to the operating room. That would be their main interest, not only for them, even for their relatives. Some of the relatives are the decision makers, even for elderly, and they were hesitant to get their parents for general anesthesia or to get them to the hospital. So this is one of the reasons that we try to simplify things, make it easier and attractive for people to go for cochlear implants. And also the other things we find it exciting is that they, under conscious sedation, they get awake immediately almost. And some of them, we wake them up by sound. So they are still sedated and we name them, and they start to wake up from anesthesia, or sorry, from the sedations by cochlear implants, and some of them tearing intraoperatively. So this is all an interesting things that keep us more and more interested to provide patient with these solutions. And I agree that we modified our surgical technique to make it faster and safer for our patients, to limit the operative time, and also for this conscious anesthesia. So almost a dynamic change in our centers in all aspects to reach to the patient expectations and their interest in cochlear implants.
Okay, thank you very much, Rahman. Let's finish our journey. Let's go back to Munich to meet again Professor Joachim Müller. And now Joachim Müller is going to deal with one of the most important issues of this topic, which are the real benefits of bilateral cochlear implants. Joachim?
Hello again. I'll share my screen. And thank you for
there you go.
Asking me a second time to summarize about the benefits and the future of cochlear implants. One of the questions we were interested is if we implanted both ears, which is the better ear? And we could not decide. In our population, for roughly 40%, it was the first side, for roughly 40% is the second side, and for 15%, both ears are equally good according to speech understanding in the patient group with sequential surgery. In those who had simultaneous surgery, there was no difference in the preference for the left or for the right ear. So the conclusion is when we implant both ears, we always implant the better ear. We have seen in the beginning that patients have access to head shadow effect, to squelch effect, and to summation effects. This is known from research in the early days, also together with Blake Wilson at the RTI. And the scratch down on the bottom of the slide where the two implants on both sides were fitted independently to fill in the gaps the first implant has decided is, so to say, similar to what nowadays is popular in terms of anatomy-based fitting, that you use the position of the implant and adjust two sides or adjust the two sides to each other so that the gaps are filled in. But in consequence, the interesting thing is that the bilaterally implanted patients had access to all the psychoacoustic effects that are known from normal hearing persons. And as I said also before, children need to be implanted early, and they need to be implanted before the age of 18 months, and then their development compares to normal hearing children. Well, in 1996, our promise was that bilateral implants are better than unilateral one, and we have seen that it's better speech understanding in quiet and in noise. We have seen that we can restore directional hearing, and the development of children also in terms of lexical skills is better than with one implant. But to analyze the development of these children brings an aspect of quality of life into discussion. However, for a surgeon, it's difficult to assess what is quality of life, how to measure. The difficulty is that everyone, especially every politician, thinks that he knows what's quality of life. And it's a very subjective, overarching term, which is, to my understanding, difficult to access. So what we did, our psychologist of the team applied questionnaires to bilaterally implanted children at early age. And we thought that the early implanted children rank higher than late implanted older adults. The young children especially enjoy quality or enjoy their life more than bilaterally implanted older adults, even they reach high scores compared to the normal or deaf population. And the most interesting thing for me was the results of the satisfaction with life scale in these bilaterally implanted kids. And they scale in this questionnaire exactly at the same level like their normal hearing pair at the same age. So the self-assessment of a bilaterally early implanted kids is comparable to the self-assessment of a child that was born with normal hearing. And I think this is quite impressive and confirms our assumption from 1996. But quality of life is more than data and questionnaires. And that's something we could experience last year in Japan. And I will welcome with this Medal Japan, who just switched in the meeting. These physicians were all bilaterally implanted subjects. And the way they produced music that we enjoyed, that they enjoyed, was very impressive. And I can tell you, even the after-work party in a little jazz pub called Noisy Duck was even more impressive and gives you an idea how we can restore quality of life with bilateral implants. For the future, developments may implement pinna characteristics like Willy Wimmer has tried with the speech processor. We have better speech coding structures implementing features that make the sensitivity for directional hearing better. And we look, for example, on virtual reality to understand better how directional hearing in principle understands. And this system where you orientate acoustically in a three-dimensional room is similar to a game that is implemented in the auditorium in Innsbruck, where you can catch birds in a three-dimensional environment. And this is exactly what these bilateral implanted subjects experience in this virtual reality room. On the two scratches on the left side, you see on the left hand, there is a bilaterally implanted subject that fulfilled the task from heading to a pointed out direction, and the right scratch shows you how the unilateral implanted subject tries around, searches the wall for orientation, and cannot manage the task. So bilateral implants increase quality of life, no way out. And that's to end with. Thank you.
Thank you, Joachim. That was very good. And that raises a lot of topics for the discussion. I would like, we have Professor Hagr again. Let's go with Professor Hagr, and then I will ask you something I want to know. Rudolf.
One important question is counseling. And is there any difference in counseling between the high developed countries and the emerging countries? This is also a question to Ranjit. And Ranjit, you mentioned the thing with a medical advantage in future. How do you counsel your patients in regard of this possible future development?
Ranjit. You're muted now.
Thanks, Professor Hagr. It's a very interesting question. With specific to counseling patients with respect to future medical advancement, one of the important key that we've got to tell them is we tell them that we have the technology for hearing preservation, structure preservation now. So with the ability of the structure and hearing preservation, it is still. Am I audible?
Yep.
Yeah. So with the ability of the structure and the hearing preservation now, it's very much possible to make advantages in the future because we don't damage any of the structures inside the cochlea. So that's one of the powerful advocacy that we have today, which influences a lot of patients to go for bilateral, despite knowing that there is a possibility which can make use of the structure and the hearing that we preserve to make use of the medical advances in the future.
Okay. We have again echo for the technical stuff. There's a lot of echo here. Okay. We are in the world of hearing preservation. And of course, we are aware that bilateral cochlear implantation are much better from a quality of life standpoint, directional hearing, head shadow effect, a lot of advantages. But I have a concern. We're living in the era also of the genetic solution for hearing loss. So my questions to the panelists is, are we preventing a genetic treatment in the future by putting the second cochlear implant? Or this is another question that you are concerned about. Who wants to start? Hagr,
Yes.
Rahman, go ahead.
This is very interesting questions, okay? And I'm sure Dr. Professor Müller and you heard this question 50 years ago from the patients. And just recently, we heard about the autophagy gene therapy, okay? So if you wait for 50 years, imagine how many patients miss the chance of hearing from both ears, okay? And also, we don't think this gene therapy will come for the coming 10 years, okay? It's gonna take a lot of regulation and a lot of concerns. And we know a lot of cases, they are not genetic causes, okay? So this is something that we need to keep it also in our radar, that most of the cases in general, we have them, they are not genetically determined, so we cannot treat them by gene therapy. And also we need to keep in mind that more than 400 genes we discover, maybe in the future more, 400 genes. So imagine how long it's gonna take for us to find the solution for those 400 genes to treat them with this therapy. And the other concern, if we treat them with the gene therapy and it failed, is they have the chance to go for a cochlear implant. So it's gonna be the question, the reverse. Are we treating them or we miss them the chance to be treated by cochlear implants? Still, the result is not clear for those patients who get the gene therapy, how much an inflammatory process they have inside the cochlea and how much their hearing improve and how long it stay their hearing. So there's a lot of questions need to be answered, and I don't think in the near future we'll have those answers. I think we have very safe technique of doing cochlear implant nowadays with minimal trauma, with minimal effect for the whole body. So we end up with organ preservations, we end up with a lot of chance, even with the cochlear implants, that we can give them the gene therapy in the futures. So I think this time we are going to continue our practice by advising patients to go with the bilateral, even bilateral simultaneous cochlear implant.
You have the same opinion, Joachim?
Well, I agree in general, and we have to also consider that, especially for children, we have to offer adequate input to the auditory system within the important biological phases. So if the child nowadays is 2 years old or 1 year old, we know from the implants, the younger we implant, the better the outcome is. So if we want to treat a hearing loss, we have to treat it early. And at the moment, we don't have any solution for genetic hearing loss. And in general, and we cannot wait. We know from patients who have received cochlear implants after a long period of deafness that the results are poor. Why should a gene therapy after 20 years result in better outcome or better connection from the auditory nerve if it is functioning than a cochlear implant? So at the moment, I don't think that we have a solution. What might be a hybrid solution for the future is to combine a cochlear implant with drug-eluting electrodes, so that a kind of biological rehabilitation will take place in the cochlea, but also all these substances need to be registered in human use, and we do not know anything about the side effects, or at least me not.
Okay, this raises a very good question concerning the time lapse between implants. Is there, in your opinion, you're the experts, a time for no-go for a second cochlear implant, both in children and in adults? Ranjit.
Well, that's it basically, of course, we all know that the duration has an impact on the outcome, but the most important thing is what the expectations are. The counseling is very important, because we all know that even if you don't get binaural benefits with the second device, you'll at least get the auditory sensation with the second device. That's another advantage. So if the patient is very well counseled, because none of us have at least me, I don't have a very clear answer to give a very clear-cut guidelines by the age, by the duration of 3 years or 4 years or 5 years, you get more benefit. Beyond that, the benefit goes down. I don't have evidence from my side. But all that I can say is the longer the duration, poorer the benefit. But however, it's not going to be zero. It's going to be, you will not get binaural benefits, but you'll definitely get bilateral hearing on both sides. That's for sure. But
we have a limit for unilateral, so we don't go further than 6 years of age or more or less for unilateral. So can we go much more time? I mean, this is not as clear as with unilateral.
of course, it's not very clear as unilateral because it depends on a couple of things. One is, the binaural benefit is not just the benefit that we get it at the more peripheral level, it's more of a central level of what's happening. And there are two things. One is if you have a child who receives the first implant below the age of 3 years, and you want to go for the second implant after 10 years or 12 years, that's one scenario. Another scenario is you have a child who receives implant at a very later stage in life, maybe 7. Even the first implant was used by around 6 or 7 or 5. And then you need to wait for another 10 more years. Then it's very, very, the outcomes are very, very bad. So it's a case by case basis. So it depends on various factors. And also looking at the etiology on the other side, the amount of residual hearing on the other side. So everything contributes to the benefit. It's just not the one particular factor that's going to contribute for the benefit on the contralateral side. The etiology also matters a lot in this case. Okay,
Joachim, we were discussing before about simultaneous and sequential, and we mainly focus on simultaneous. Sequential is also a period of time between the first and the second that should be no longer than that, or we are just discussing the same as with Ranjit?
Well, it depends, and as Ranjit said, in the end, it's an individual case-by-case decision. And we're overlooking intervals up to 9 and 10 years in between the two implants. And I'm recently implanted a boy who I implanted 22 years ago, and he was using the hearing aid on the other side. And now he's in university and finished his studies, and he experienced a hearing loss on the hearing aid side. And he's asking for an implant on the second side. And of course, we gave it to him, but the difference is 25 years. This is just a number, but it doesn't say anything about the biological condition with a stimulated ear with hearing aids over a longer period. So when discussing the time interval, we also always have to consider the residual hearing and what happened and when was the first side implanted. So,
okay. So some people I've heard some people saying recommending to use only the second implant to achieve similar results with the second implant as with the first one. Is this a right practice, or this is nonsense?
Well, in the end, the binaural hearing, even if the outcome in the second ear is poor, gives, to my experience, benefits to the patients. And this is also true for patients with single-sided deafness, whom you give an implant after even longer periods of deafness to restore some kind of binaural sound sensation. But if we're going to discuss this now with the second implant or one implant on a second ear with a normal hearing, then we will run out of time. But in the end, I feel if the conditions allow for, and we have seen good results after 40 years of deafness, and the patient is willing to take the minimal surgical risks, I would always try.
Okay.
The lessons after 30 years is you will see many more positive surprises than negative.
Okay. I know Professor Hagr wants to ask a question, but I have a couple of questions from the audience, and I want to bring them to you. First of all is one for Rahman. How soon can we feed processor on a child?
Well, in our practice, the routine practice, that we fit our patient bilaterally next day. Bilateral, and almost all the children in our center, they go for bilateral simultaneous cochlear implants. So this is for children, almost all of them, unless they have another reason, like if they are dizzy, inner ear anomalies, and they are not okay next day. But our routine is next day fitting with the children. In adult, same day fitting. Some of them intraoperatively.
Thank you very much. And the other question for the audience, you can answer any of you, and I will give you the word also, Joachim. Is there any data on prolonging cognitive decline in adults who are using unilateral or bilateral CIs? Who wants to answer? Joachim?
I'm not aware. I know the studies about cognitive decline if hearing is not rehabilitated properly, but I'm not aware of any studies that differentiate between bilateral and unilateral implants. Okay,
Rudolf, go ahead. Unmute yourself. And
I was very happy that Ranjit mentioned the WH report on hearing with some figures concerning the resources. And this is a big challenge because we are discussing on the highest level of hearing restoration, but looking worldwide, the really scaring scene is that you have in some countries, you have one audiologist for 1 million. In Europe, it's completely different. So I think one focus for the coming years should be how can we equalize this huge diversity worldwide. And I think hearing is a worldwide organization, and I think we should have our focus on this, because otherwise they have no chance to get at least a hearing aid. They have no chance to get at least one cochlear implant, and we have to make a plan, be some sort of worldwide foundation, because there is so many money in the world. We should focus on this. What's your opinion on this, Ranjit?
Well, I completely agree with you, Hagr. So I think 6 years ago, we started a project along with the Hearing Healthcare Alliance, and we established the first formal training program in Bangladesh, and to develop or an institution that produces audiologists, speech pathologists in that area. Now we're expanding the same project to 5 countries in Africa. What was there a problem? I could hear some echo.
No, it's echo, yeah, but you can continue.
Okay, so I mean the way forward is, yes, we need to educate, and we need to create equalization in audiology training program across the world. That's very important, because that once we start an equalization of audiology program across the world, and we come out with some bridge programs, it's the way forward to build human resources across the globe, especially in emerging nations. And that's exactly what we are doing now. I think the Hearing Healthcare Alliance website is alive. So the audience who's watching can just go on to the Hearing Healthcare Alliance. It's primarily to create education in the field of audiology to improve human resources in emerging countries. So it's on, and as Professor Rudolf Hagr said, there is much more to do. I mean, this is one foundation which is already working on it.
Okay, I'm sorry to tell you that we're almost out of time. I have tens of questions that I could ask the panelists. I know you can still, the audience, be there for more time, but 4:30 is the limit of our roundtable. And well, maybe we can repeat another roundtable on bilateral cochlear implantation, because this is a very, very appealing topic. I think, as a general conclusion, it's obvious that from a purely theoretic standpoint, bilateral cochlear implants are better than unilateral cochlear implants. That's for sure. However, unfortunately, we don't live in utopia, and real life is more than just pure theory. Real life makes things a bit more complex. Number one, as was mentioned by Professor Müller, life is not black and white. We cannot say we always do this or we always do that, because the situations are completely different. So you have to individualize, which is the crucial key for success in medicine. Money is a big problem, but as was said by Ranjit, it is not the only problem. It is it's something which is there, but you need to create awareness, because money will appear if you have the convincing ideas to tell those responsible of the economy to provide money for bilateral cochlear implants. And my third conclusion will be something that Professor Hagr was mentioning. You don't spend more time thinking about not doing something because something will come in the future. I don't know if you had the same problem. It's like when we are buying a new computer, a new laptop. There's always something new 2 months later, but you cannot wait always for something to happen in the future. And I think the situation right now is that bilateral cochlear implants are very good option for a lot of patients, again, individualized and move forward in this field. And with this, I would just like to remind you that at Hearing, our group, we'd love you to visit our webpage at www.hearing.com. There you can find a lot of tools: the hearing preservation calculator, the counseling platform, the fitting tool, the electroacoustic stimulation fitting tool, and we also have the Boost Hearing. Is one of our pillars, is our educational platform, which is basically a learning management system. You're invited to use it anytime you want. Here you can find courses, you can find masterclass, you can find genetics and cochlear implantation lectures, all kind of scientific information. And as I said at the beginning, this roundtable has CPD accreditation. You can request the accreditation by email at boosthearing.com, here as I said before, and the procedure will take some time, but at the end you will have about 6 weeks after the request, you will receive 1.5 points for the hour-and-a-half duration of this roundtable. As I mentioned before, at Hearing we are a very active group. These are the conferences where we have been or will be during this year, 2024. We were in Las Palmas at the beginning of the year. We have been in Vienna very recently, and we will be in Buenos Aires, in Rome for the Policy Society, and in Abu Dhabi, as Professor Hagr mentioned, for the ACIC. And just a short comment on the next scientific event that the Hearing will be, which is the 8th World Congress on Cochlear Implants in Emerging Nations, that will take place in Buenos Aires, Argentina, and will be directed by Professor Mario Cernotti. We have been discussing a lot of about this afternoon, today, this morning, for depending on where you are, or this evening, and we have been discussing a lot on the situation of emerging nations, of people who are not having all the resources that we have, at least in Europe or in some other countries. So this is a very good option to meet. And please, if you want to have more information about the Hearing, about the roundtable, about any other thing, send us your inquiries and contact us as www.hearing.com. We will be very pleased to answer your questions. We hope to see you all soon. I would like to thank you for your patience and being there and staying for the whole 90 minutes there. I would like to thank the panelists. I would like to thank our chairman, and let's hope to meet in person very soon. Meanwhile, have a wonderful summer or winter, depending on your location, and goodbye.